Anastrozole versus Tamoxifen for prevention of loco-regional and contralateral breast cancer in postmenopausal women with locally excised ductal carcinoma in situ.
Thank you, Kent. It's a pleasure to present these results on behalf of the IBIS Working Party and my co-chairman, one of which, Professor Howell, is actually here. If there's any clinical questions, the other one, Professor Forbes from Australia, unfortunately was unable to make it, but was originally going to actually give this presentation. Disclosures are given. We know that the third generation aromatase inhibitors are more effective than tamoxifen for treating women with invasive breast cancer, but there's really limited, in fact, very little data before these presentations. Also, there's a simultaneous publication that's going to occur with this in the Lancet today on the B35 trial from the NSABP about the role of aromatase inhibitors in DCIS. And as I said, NSABP reported at ASCO, and now it will now be available, a 27% reduction in recurrences with anastrozole compared to tamoxifen in this population. So that's really the background. Our trial was just under 3,000 patients. It was virtually everywhere except North America. 14 countries participated, 236 centers. Total recruitment was 2,980 patients. This is for women, postmenopausal women with locally excised DCIS, which was found to be estrogen receptor positive. And we had an amendment which allowed atypical hyperplasia and LCIS, but that was very few patients in this study. Median follow-up 7 years. The results were indication of really very similar effects on overall recurrences. A slightly better effect for anastrozole, hazard ratio of 0.89, so 11% fewer recurrences overall, but this was not significant. And if one looks at the subgroups, we saw, this is just focusing on the invasive recurrences, some indication that anastrozole might be working better for HER2 negative patients, again, not significant. ER positive recurrences were actually more reduced by anastrozole. And a subgroup, this was not a pre-plan, this was a post-hoc evaluation. If we looked at ER positive, HER2 negative tumors, we did see a striking effect in that particular group of almost 2/3 reduction in recurrence. So some interest in subgroups, but again, all of that was post-hoc. I think one of the important things, which unfortunately isn't in the Lancet paper, it wasn't allowed, but we will be showing it, is that we did do a simple meta-analysis with the B35 trial. Our results are shown on the top line there, that 11% reduction. NSABP had a 27% reduction. If you put these two things together, you end up with a 21% reduction in all breast cancer events associated with anastrozole in favor of over tamoxifen. And that is statistically significant if you put those two studies together. Although, as I said, the overall efficacy differences were small, we did see dramatic differences in side effect profiles, in particular other cancers where overall there was not a significant difference, but the types of cancers were dramatically different. Gynecologic cancers, particularly endometrial cancers, there were 11 in the tamoxifen arm and 1 in the anastrozole arm. And that's probably a combination of two effects. We do know that tamoxifen increases endometrial cancer by 2 to 3-fold, and there is emerging evidence that the anti-estrogenic properties of anastrozole actually reduce endometrial cancer. So together, really quite a dramatic reduction in endometrial cancer. A somewhat newer finding was a fairly strong effect on ovarian cancer, which has been seen to a small extent in some of the previous studies looking at anastrozole, but very, very big effect here, 5 versus 0. So that's interesting. We also saw big reductions in skin cancers. Again, that's been suggested earlier, primarily the non-melanoma skin cancers. And other cancers were slightly in the other direction in favor of tamoxifen. Colorectal cancer was 10 versus 5, and small differences. So overall, the effect was not that striking, but there were clear differences for gynecologic cancers and non-melanoma skin cancers. In terms of fractures, again, this was not unsuspected. We saw a higher fracture rate with the aromatase inhibitor. Again, this is probably a mixture of the fact that this does lower bone density and does increase fracture rates, and evidence that tamoxifen actually does reduce fracture. So it's probably a combination of two things going on there. Thromboembolic events were more common with tamoxifen. Again, that's been seen previously, dramatic kind of differences. Overall, major thromboembolic events reduced by about 2/3 with anastrozole compared to tamoxifen, or probably more accurately increased by a factor of 3 with tamoxifen compared to anastrozole. Cardiovascular events overall, there were a little bit more in anastrozole, no differences in myocardial infarction, a somewhat surprising effect on strokes, cardiovascular accidents, transient ischemic attack events, which were more common in anastrozole. This has not been seen previously. We don't really have a good explanation for it, something I think needs to be looked at more fully, but it was significantly higher with the anastrozole arm. In terms of other side effects, musculoskeletal aches and pains are known to be more common with aromatase inhibitors, and we saw that very, very clearly. 64% reporting that overall with anastrozole, 54% with tamoxifen, so about a 10% absolute difference. Arthralgia, joint stiffness, paresthesia, carpal tunnel syndrome, osteoporosis, all more common with anastrozole. Muscle spasms, very much more common with tamoxifen. Again, this is a known finding. On the other side, we saw virtually the reversed effects for vasomotor and gynecologic symptoms, hot flushes or hot flashes here, vaginal bleeding, discharge, all much more common with tamoxifen. Again, about a 10% absolute difference going in the other direction. Vaginal dryness was the only effect that we saw that was more common with anastrozole. Again, that's been reported previously. Overall, that led to virtually identical adherences, really not bad, 5-year compliance or adherence, 67%, and virtually identical between the two treatments. This is typical of what's been seen in both the adjuvant studies for women with breast cancer and in the prevention studies, roughly a 65 to 70% 5-year adherence to treatment, which isn't too bad, and no difference between the arms. So in summary, no significant differences in recurrence between the two drugs in our study. But if you look at all of the data from the B35, the attack, and from IBIS-2, there is evidence to support lower recurrence rates with anastrozole compared to tamoxifen. No overall effect on other cancers, but there were very clear site-specific differences. Endometrial cancer, ovarian cancer, and skin cancer more common with tamoxifen. Some increase in gastrointestinal, lung, and lymphatic cancers with anastrozole, but not significant. And really, there's no, I mean, we've reported the data on death, but there's really nothing to say yet. It's too early to look at mortality in this study. Expected differences in the side effect profiles, more fractures and joint-related symptoms with anastrozole, more vasomotor and gynecologic problems with tamoxifen. This unexpected increase in strokes, cerebrovascular accidents with anastrozole wasn't seen in previous studies, so I think the significance of that is very unclear. And overall, there's no clear differences in efficacy. Some slight favor, I think, in terms of anastrozole when you look at all of the data, but there are significant differences in toxicity profiles. And we feel that anastrozole is now another agent that can be considered for ER-positive DCIS. Clearly, there are different side effect profiles, so this is yet another choice. Women who can't take tamoxifen, for example, because of prior deep vein thrombosis, the AIs are very attractive. If there's concerns about particular concerns about fractures, then tamoxifen might be better. So this offers, I think, yet another choice. Just like to acknowledge all the participants. This was a multinational, multi-center study with many groups around the world being involved. And the results are available online with the B35 results. today in Lancet. The full results are available in print at this moment. Thank you very much.
Thank you. Jack, I know the curves that the Kaplan-Meier curve or the recurrence curve includes both DCIS recurrence and invasive recurrence, and then the other graph that you show is just invasive recurrence, which I guess is the primary endpoint, although recurrence of DCIS is also important in the sense that when it happens, patients frequently need to have a mastectomy. And so there would be some benefit accrued just by reducing DCIS recurrence. If you look at that as a separate item, what do you?
Yeah, we've reported that. We'll report that fully. I've abbreviated here. We actually saw no differences in DCIS recurrences. The overall effect was very much, which was the primary input was DCIS and invasive recurrences, but the effect was really only in the invasive recurrences.